Does that mean you want it to be the end of my presentation already? Does that mean my time is up?
So thank you for the choices.
So, when I started doing maggot therapy in 1990, I didn't see much pain. That was because my patients were primarily spinal cord injured patients and diabetic neuropathic patients who felt no pain. Only about 5% of my patients had pain with the maggot therapy. So I did appreciate pain, but I didn't see it in the numbers that we're seeing now. Indeed, over 30% in some series. And so we need to address that. And I recognize that. Some people are addressing it with lidocaine topically during maggot therapy. And that prompted the items, the research that I'm going to present to you. But I'm required, before I get into this, to note that I am on the board of directors of the Better Foundation, which supports patient care, education, and research in biotherapy. My laboratory at the university broke off and became an independent entity in 2005. So I'm a co-founder in Monarch Labs, which produces and distributes medical-grade maggots. Lastly, I am a staff or a physician, not a staff physician, but a clinic physician at the Orange County Health Department, which sees HIV patients who have no insurance and no other financial support. And as a consequence, I also do some consulting to HIV pharmaceutical manufacturers. Now, if I haven't used up all my time with that, let me tell you that although there are a few reports to me personally about lidocaine on the wound during maggot therapy to control pain, no one's studied how effective that is, and no one's studied the effect on the maggots of that analgesic. And so I thought that's the first place really to begin, because if it's harming the maggots, then you're not getting into debridement, and there's no reason in getting even further. The structure of lidocaine appears as before you on your screen. And let me describe or remind you, because you've already heard, that the mechanism of action is the inhibition of ion flux over the cell membrane. So without sodium and potassium going across the cell membrane, the neurons are unable to communicate pain to the brain. But one of the potential side effects, and sometimes a therapeutic effect, is that you also have on other nerves and some, it has an anti-arrhythmic effect on the heart, which in high doses can be an arrhythmic effect on the heart. So there are significant systemic complications of lidocaine as well. Its onset of action is rapid, that's good. Its half-life is very brief. That is either good or bad, depending on how you want to use it. It's readily absorbed through the tissues. And so putting it on a wound means a great likelihood that it will be absorbed into the neurons that sense pain. There are even topical delivery systems that now exist for lidocaine called Lidoderm and others. We're going to skip some of the pharmacodynamics of lidocaine in order to make up for the time. So we did a series of 3 experiments. The first thing we did was add a variety of concentrations of lidocaine to a wound model with maggots. The wound model, very basically, is pureed beef liver, 50%, and 50% trypticase soy agar media, and the ingredients and the methods, and also the proof that it is an adequate model has been published back in 1996. So we placed the maggots on this wound model and added lidocaine in various concentrations. What we saw, every 4 hours we added more, right? Every 4 to 6 hours we added another milliliter of the lidocaine suspension, and what we found was that the maggots were dying in significant amounts. But even when 0% lidocaine, that means just water, was added to this model, the maggots were drowning. The maggots were drowning. Now, increasing the lidocaine to 0.06 had a significant rise in the mortality, but even the water alone was pooling, so this was not an adequate study. Well, it was a study, but it was not an adequate model or an adequate mechanism to lead us to success, because the goal of this is really to find out if there is possibly some way of addressing the pain with lidocaine. So we did a different series of experiments. We took 500 microliters of 1% lidocaine, commercially available in vials, and we added that every 4 to 6 hours to the wound model, but we then removed it after 5 minutes, after 10 minutes, after 50, 30, 60 minutes. Because after all, clearly the maggots were drowning, but in a real wound, you would have mechanisms to wick away that fluid, and you wouldn't expect the maggots to be drowning in real life. So we removed it mechanically. And what we found was that for short periods of time, the maggots did not succumb to the fluid. A third experiment, or series of experiments, in the third series of experiments, we fed the maggots a mixture of the lidocaine in the tissue, in that liver agar itself. And now we saw that again, the larvae were able to develop and mature right on time, as long as the lidocaine reached no higher than 0.1% of the entire media. So what this leads me to think is that in low enough concentrations, the lidocaine did not impair the maggot's ability to feed and develop, and therefore shouldn't impair their ability to debride. And it might be possible to administer lidocaine in those amounts, and as long as those amounts are sufficient to control the pain, maybe there's some possibility of analgesia. So a clinical evaluation of topical lidocaine for MDT-associated wound pain might be warranted, and we would certainly welcome any collaboration with teams that want to participate with us in such a study. Maybe there is some promise. And with that, bon appetit.